So one of the research abstracts we are presenting at the IMW meeting this time is on minimal residual disease testing in light chain amyloidosis. In the recent years, we've heard a lot about MRD testing in multiple myeloma, mainly that it's a prognostic tool. We don't know yet if it's a predictive tool. We do know that people in multiple myeloma who achieve MRD negativity do better, regardless of how they got to MRD negativity, regardless of the treatment type, both in frontline and relapse setting. And we wanted to investigate if this is still true for light chain amyloidosis, which is a disease where the clonal disease burden is much lower, but even that low affinity clone can lead to severe organ damage. So we looked at a cohort of patients who got treated at Mayo Clinic. These were about 53 patients. Most of them were in VGPR or CR, about 96%, half in VGPR and half in CR. And we found that 2/3 of the patients, about 62%, were MRD negative by next generation flow cytometry. And it's important to note what method of testing you're using for MRD, because that can really influence the outcomes. And so this was 10 raised to power minus 5 sensitivity and was done by an 8-color flow based on the Euroflow methodology. So about 2/3 of these patients tested by this method were negative by MRD testing. And what we found was patients who were tested after frontline therapy were more likely to be MRD negative, about 70%, versus patients who were more relapsed. But about half of them could still be MRD negative. We also found that patients who were MRD negative, after a median follow-up of only 14 months, which is pretty short for amyloid, were more likely to have a better progression-free survival. So at 1 year, the PFS was 100% in the MRD negative group versus 71% in the MRD positive group. What was also very encouraging to see was that a deeper hematologic response by MRD correlated with organ response. So patients who were MRD negative were likely to have cardiac response at the time of testing, which is very important in these patients because the major cause of mortality and morbidity in amyloidosis is cardiac involvement. And so this is encouraging to see that if we can get them MRD negative, the likelihood of cardiac response really increases. About 2/3 of those patients had cardiac response versus only 25% of the patients at the time who were MRD positive. So that's very encouraging to see. So this is preliminary data, of course. There is very limited data in light chain amyloidosis, and we hope that going forward, we and our colleagues can have more data and see at what time point should we measure MRD. What will happen if someone is MRD positive and we give them risk-adapted therapy? Will that lead to better outcomes? And so those are areas we still need to investigate.